welcome to the 10th, 11th session of the Nomics series, where we talk about how genomics is being utilized across clinical and healthcare settings. I'm Aarti Darda, your host for this webinar, working at Carkinos Healthcare as a bioinformatician. Today we have with us Dr. Omshree Shetty, an assistant professor and scientific officer E in molecular pathology division at the Tata Memorial Hospital. And today she will be speaking on HRD testing in clinical practice. So before we dive into her insightful presentation, I would also like to highlight that she has wide expertise in molecular diagnostics, genomics, next generation sequencing, and clinical implementation of NGS. And she has pioneered the clinical implementation of NGS at Tata Memorial Hospital, one of the premier cancer centers in India. She has extensively published in molecular oncology and contributed to the key datasets from India on solid tumors and the profiles and genetic epidemiology of cancer mutations. She is also a member of the Association of Molecular Pathology and the American Society of Clinical Oncology. Without further ado, I would like to welcome Dr. Omshree. The stage is now yours.
Thank you, Dr. Aarti, for the kind introduction. It's okay. HRD testing in clinical practice, the picture what I've depicted here is like basically I feel that it's wading through rough waters. I guess this is what currently the scenario in India, at least when it comes to HRD testing. So without much ado, next slide, please. So pathways of DNA damage repair. This is just for the beginners who would want to understand what exactly is DNA damage repair and why we are talking about homologous recombination deficiency repair system here. So there are different kinds of agents which would lead to the DNA damage. And at the same time, we also have enough mechanism to restore that DNA damage, or there is an intrinsic mechanism for DNA damage repair through various means like through signal transduction, through transcriptional regulation, tolerance, or apoptosis. And there are several key mediators or key players for that. Next slide, please. So a homologous recombinant deficiency in cancer is basically error-free repair of double-stranded DNA breaks which arise during the DNA replication. So if you can see in the picture given here, there are a lot of molecules come into picture. Like BRCA1, which with the help of exonucleases takes care of those breakages, followed by PALB2 and BRCA2 gene along with RAD51 loads on single-stranded overhangs. It corrects those things, and then eventually those damages are repaired. So all these genes, which are key players like BRCA1, BRCA2, and the associated genes like RAD51, PALB2, PALBC, these are all the genes which are involved in the homologous recombination repair pathway. Okay, so this constitutes for the homologous recombination deficiency. Next slide, please. So that's how like the double-stranded breaks are introduced in the DNA due to some agents. It would lead to high fidelity DNA repair, and that could lead to cell survival. Next slide. So double-stranded DNA breaks if there are any mutations in these BRCA genes, so these DNA repairs are more error-prone. And once these are error-prone, DNA repairs can lead to a lot of breakages and eventually lead to cell death. Next, please. So why test for HRD? Why is it so important that, anyways, the cell is dying its own death? Why do we need to explore this mechanism so intensely? So when the homologous recombination repair intact cancer cells, where this mechanism is very much intact, so even there are breaks induced, it is getting repaired, and then that the cells are proliferating and growing. Going about on their own. But whereas when you have in a cancer cell, they have been identified with homologous recombinant deficiency, it is very much easier to target those, and there are platinum-based chemotherapy, or there are synthetic or lethally introducing polyadenose diphosphate polymerase inhibitors. So we can make those cells die, or we can use several therapies. So that would be like a targeted approach, and that's why it is important to identify in a disease whether there is homologous recombinant deficiencies existing. Next, please. So what are the genes involved? Like I already mentioned, BRCA1 and 2 genes are the most studied. They are also there in germline and somatic as well. So other genes of the HRR pathway, like we saw in the first slide, apart from PALB2 and RAD51B, RAD51C, there are close to 24 genes which are there. And what are the entities which would harbor these HRD? Common cancers are mostly ovarian, breast cancer, prostate, endometrial, and pancreatic cancer. Next, please. So, what are the testing strategies? One is either look for the cause of HRD, other one is that look at the effect of HRD. So, how are we looking for the cause of HRD? We can assess the presence of specific mutations. Either you look for BRCA1, BRCA2, or any other HRR pathway related gene, so which we can do with the HRR gene testing panel, where we are specifically looking for specific mutations. When we're looking for effect of HRD, like because of these homologous recombination deficiency repair system, what is happening? We are having large chromosomal alterations. There could be, large structural aberrations, which also because of the loss of HRR. So that is, again, it leads to HRD genomic instability. So we have two components here. One is homologous recombination repair that is evident from the pathway, where we are looking at specific genes in that pathway and we are studying those mutations. Other one is the effect of HRD. Because of that deficiency, there are those structural changes, or there is genomic instability. So we have these two things, HRR and genomic instability. So collectively, when it comes, that is called as HRD. And that's how the testing has evolved. Next, please. So the approaches to detect HRD include genetic testing and genomic instability score, like I've already mentioned. Like we're looking for mutations, we're looking for genomic instability. Now, this test has evolved over a period of time. Initially, when Myriad looked into it, which is still considered as like the gold standard for detecting HRD, apart from looking into the mutations, they looked for those loss of heterozygosity. They also looked for telomeric allelic imbalance, and they looked for large-scale state transitions. So when all these three were together, they connected it with an aggregate score, and that score, or which is called as HRD score, more than 42, was designed for Myriad test. Okay, and that's how the testing algorithm came, and then they kind of patented this. So they were looking looking for mutations and looking for the genomic instability using these three approaches: LOH, telomeric allele imbalances, and large-scale state transitions. Next, please. So what are the approaches? Either you go by the NGS way, or one can go by these SNP arrays or methylation. There are multiple approaches. Next, please. So that is about looking for the mutations, like, from the tumor tissue, you take out the DNA or look into the FFP slide, mark out the area, do NGS and look into the only BRCA gene, or you can also look for the entire HRR pathway. Then those LOH, TA and LSTs can be looked by various other methods like microarrays, or look for those loss of heterozygosity using different studies. Next, please. So then it comes to mutations. What are we looking at these mutations? Are we looking at certain hotspot mutations, or are we looking at the entire genome for those things? So basically, when it comes to BRCA1 and 2, the mutations which are depicted are scattered across the entire length of the genes. And these mutations could lead to these truncated proteins. And all these deleterious alterations can also frequently occur in exon coding domains, and which would interact with the BRCA1 binding proteins like BARD1 or BRIP1 and PALB2, which are along with RAD51C, 51D, and also with RAB80. So all these are also considered as breast cancer and ovarian cancer susceptibility genes. Next, please. And what are those non-BRCA HRR pathway genes? So like the BRCA1, BRCA2, along with that, we have RAD51, BIP, PALB2, ATM, CHEK1, and CDKN2 and Fanconi anemia genes. And homozygous deletion, specifically in the PTEN mutations or CHEK1, lead to high HRD associated LOH score. These need to be kept in mind. Next, please. So how do we assess these non-BRCA HRR pathway genes? So these are actually low prevalence, and it's difficult to determine the association of individual genes with the outcome. So even when we are testing HRD, so sometimes we get these genes, we really do not know whether to call those, if the presence of mutations in only those genes, we would mention, okay, there is alteration present in the HRR pathway genes, but that wouldn't account it to being an HRD positive case. So because of the low prevalence, I guess more and more testing we do, we will be able to come out with it. And it is also difficult to determine like which tend to be gene to be included in the panel. And also most of the time we end up annotating them either into variants of unknown significance. Next, please. So does it mean that we should only stop at BRCA testing alone, or should we go ahead with something else? Like how do we go with the genomic instability score? Next, please. So why do we need to look at this? This is an important question that need to be addressed. So many clinicians also say, okay, you just tell me about the BRCA status, good enough. Anyways, 50% of the time you would see only BRCA mutation, but that's not the case. So we can say that like almost close to 25% of the tumors are BRCA1 or 2 positive, of which again 15% is germline and 10% would be somatic BRCA mutation. And there is 25% would be other causes of HRD. So even then, we are still missing on 50% of the lot, so which need to be explored further. Next, please. So as I already mentioned, the HR non-HR deficient and HR deficient. So one need to look for the causes and whether it is the MMR germline or whether it is a CCNE amplification. What are the other factors apart from genomic instability? So that HRD test would be able to tell you. Next, please. So HRD genomic instability testing has the potential to identify more women with HRD than HRR panel alone. How? Blood, as we already mentioned, germline can give you close to 13 to 15% of mutations. Tumor, either germline or somatic, close to 20 to 30%. And the entire genomic instabilities and other additional 50%. To complete the story together, we need everything in one basket together. Next, please. So, okay, so we understand that there is HRD. So then what are we going to do? So patients who are positive may be selected for PARP inhibitor therapy based on FDA-approved companion diagnostic test. Initially, it was only Myriad, but now there are many more who have, which have got FDA approved. So what are the drugs which are there? Olaparib, niraparib, and in Europe, Myriad My Choice may be accessed by some other countries also. Next, please. So what is the methodology that nowadays laboratories are using? It is NGS. So that is definitely the preferred method. So it uses combination of different library preparation method need to be adapted depending on what kind of panel and also the expertise available to handle the FFPE tissue. So either the amplicon based library preparation or even the capture based library preparation can be done. Next, please. So what are the sample types? As I already mentioned, this could be FFP specimen, fresh frozen specimen, if available, can be considered. Because usually, many of the times, close to 10 to 12% of the rejections or uninterpretable cases are predominantly because of the quality of the DNA that we get. If the DIN value is not good, it gets rejected at that level because there's no point in taking that sample ahead. It is definitely not going to give you any results. So quality of DNA, so that means type of FFPE specimen is very important. And then ovarian cancers are characterized by complex and changing genetic profiles. So BRCA1 and 2 tumor testing results can potentially vary depending upon disease stage and sample site. So one need to choose you need to have a very good consultant pathologist who can actually guide you like what tumor sample to be taken, which one, whether you should not be taking the initial biopsy or if you have a resection specimen, choose that. Even from that, the one which doesn't have much of necrosis, have a very good tumor content, well-preserved tissue need to be taken. So then data from somatic mutation is still emerging and the dilemma is whether primary tumor or metastatic tumor. So primary is most of the time easily available. So you really don't know what was the genetic profile in the primary versus in the metastatic because it tend to evolve over a period of time. So also metastatic tumor tissue will have more information regarding resistance and accurate indication on response to targeted therapy. Next, please. So based on all these things, so what we come to a consensus that whether if it is HRR pathway, you know that what are the alterations, you want to come back and see whether there would be a response to therapy or not. Similarly, genomic instability will also give you that whether it would predict or it can indicate. So it is a complete collective algorithm, so which says yes, HRD is very much needed. Next slide, please. So so we talked about the mutations, like how important it is for us to see. Then coming to genomic scars, what exactly we mean. So definitely an indirect measure. It is basically an effect of HRD. So percentage of genomic regions with loss of heterozygosity by SNP sequencing. So this approach is being used by Foundation One medicine. Whereas genomic instability score, which it takes into account LOH, telomeric allelic imbalance, and LSTs, are done by Myriad. So nowadays, many of the things are using some other algorithm to look for those genomic scars. So what are those? Next, please. That's called as low pass whole genome sequencing, which was initially introduced by Sophia. And now there is in fact an entire study, and they're also doing a shallow whole genome sequencing. So shallow whole genome sequencing or low pass whole genome sequencing are nothing but you're looking into the whole genome sequencing at a very low depth of coverage. So where it would look into account of all those large structural changes or any kind of truncations and genomic instability would be uh, looked into by the copy number amplification profiles. So this, along with the like intense bioinformatics network, which is taking into account of the TCGA database or the currently available data, that would derive a genomic instability score. So that algorithm derives genomic instability score. So to summarize, the shallow whole genome sequencing or low pass whole genome sequencing is a quick, reliable, cheap technique, and that can be easily applied to clinical samples, including FFPE. So you really don't need a good fresh tissue or a fresh frozen tissue or blood or anything. You can very well do it on FFPE. And the bioinformatic pipeline is straightforward and computationally light with the number of large genomic alterations as a biomarker. So just remember that. So the earlier test which made use of LOH, TAI, LSTs, low pass whole genome sequence surpasses all that. You do another set of NGS preparation or a library preparation in the laboratory when you're checking for HRR panel. At the same time, you're also making a low pass whole genome sequencing library prep, and you're running it at a lower depth, and then the algorithm takes over, and then you get a score. So that's whole thing is low pass whole genome sequencing. Next slide, please. So once we do all these, what to expect from the HRD report? What are we supposed to see? We are supposed to identify, like a test should be able to identify single nucleotide variations, whether there are any indels in the BRCA1 and 2 genes, whether there is any loss of exons, are there any copy number variations. So the tests in the market, of course, there are many players are there, and there are even laboratory developed tests are coming up for HRD. But the most commonly known are Myriad, TSO 500, Foundation One. These all three are like FDA approved. Amoy DX, Sophia HRD. Next, please. So how are these tests different from each other? So just to summarize, like looking into all these things, what we can make sense is like coverage and the explored genes, large rearrangements, sequencing capacity, like what platform one is using. Is it Thermo Fisher? Is it NextSeq or NovaSeq or MySeq? Based on that, it would also depend. And again, LOH, LST, TA, like I already mentioned, like which are the kits which are using. So if you look at A and B, so A would comprise of panels which would have pipeline, which would derive somatic BRCA1 and 2, and another pipeline would look into the genomic instability score, correct? Whereas when you have a B type of testing, where you have one panel which is only looking into the BRCA1 and 2 status, and there is completely another pipeline which is looking into the genomic instability score. So B has two different sets altogether. So now let's see which are the tests which makes use of A and B. So like My Choice Myriad has a combination of both A and B. Illumina TSO 500 makes use of GIS. Again, it has a combinatorial panel A. Sophia HRD, I think when it comes to Thermo, it uses B, but when it comes to Illumina, it's panel A. And then GI Scar, Swiss, and Leuven HRD test makes use of this algorithm. Next slide, please. So test options, Myriad based is a like a gold standard because they were the first ones to develop that. So it's not that they are something superior or anything. Most of the tests nowadays are almost on par. I mean, there have been head-to-head comparison with Myriad with a lot of other kits, and there have been several papers if you look up in the literature. So still the go-to would be Myriad Satellite Labs they're looking into, or Illumina TSO 500, HRD CGP, and because they are in collaboration with Myriad. And then there are alternative diagnostic partner kits are like Amoy DX, Thermo Fisher, QIAGEN, Sophia Genetics. And then there is local laboratory developed tests. There's an interesting paper which actually talks about where they have compared all these test kits, and they talk about like which are really good ones and which are very helpful and which are not so helpful and which are quite complicated. So you can go back to literature if you're more interested, and we can read about those. Next, please. So still moving on to genomic instability, so I guess most of us are very much pro in NGS and looking at specific gene panels. This is genomic instability score is something where always it's been the most debated, what exactly we are looking out of it and what does it tells you. So when the genomic instability score, it kind of distributes the disease into two, either HRD negative or HRD positive. And according to this study which was presented, what was observed that HRD positive is usually associated with the BRCA deficient tumor, specifically in ovarian cancer. And the cutoff was so that the 95% of the BRCA deficient tumors were HRD positive, which was not the case in HRD negative. I mean, you would still have HRD negative, but BRCA deficient would be like fairly a very low number of cases. So with that, next slide, please. So how do we decide, like when do we call a case as HRD positive? So we need to take into account both the genomic instability status and tumor BRCA mutation status, or T-BRCA-M. So how does it say? The genomic instability status, if it is positive and your tumor BRCA mutation status is negative, your final status would be positive. And if you're, again, if the genomic instability status is positive, tumor BRCA mutation status is also positive, final status would be considered as positive. Also, if your genomic instability score is negative, tumor BRCA mutation is positive, you would still call it as positive. And when it is negative, when both of these things are negative, it is called as negative. Let me tell you, when we are looking into this, when we are looking into the HRR pathway genes, even though there are some HRR genes which are positive, but if they are non-BRCA1, BRCA2, it cannot be called as HRD positive. You would say that test is HRD negative, but HRR genes are positive. That is what you would be writing in your report. Next slide, please. So what does Myriad My Choice has to offer? So again, HRD positive, yes, it has to have a tumor BRCA mutation, yes, and genomic instability has to have a score of more than 42. When it is HRD negative, when the score is less than 42. Now the next question arises is, what exactly is this score? Like, how do we decide onto this score? Is there any cutoff? Like, what if my test doesn't reaches 42? What if I get a score of 0? So then is it that important? Go to the next slide, please. So Myriad has more than 42. Foundation 1 has a loss of heterozygosity score of 16. Sophia HRD says that genomic instability is positive if it is more than 0. So there was an interesting paper again published. Next slide, please. So where they have actually compared almost close to, I think, 300 cases where they have had the Myriad My Choice score, and they had the Sophia HRD testing was done, and also the Amoy DX testing was done. And then based on the scores which they received for HRD from Sophia as well as Myriad and for Amoy DX, they just compared. So when it was seen that, I'm sorry that these figures are very smaller, really smaller. So if you can see on the scale over here, so the score of 42 of Myriad comes closer to HRD 1, that is Sophia's score of 2. So the cutoff which was derived for Sophia HRD 1 is like 0. So anything more than 0 was considered as positive, anything less than 0 was considered as negative. And if you see on that chart, the score 0 of Sophia HRD corroborated to the Myriad My Choices score of 37. And when it comes to the assay sensitivity and specificity, Sophia HRD testing was almost like close to 95% was concordant, whereas the other kits did not hold true for this, including Foundation 1, and I guess even TSO 500 has not reached to that level, which has been again published. So I'm not saying it just on that. So, and this is an excellent paper which compares and it tells you the importance of what score one need to take. So based on this paper, you can understand, like, the scoring is nothing but an algorithm derived by each of the companies based on their bioinformatic calculations. So whatever algorithm was there, so they would come up to a score of 42 and they decided that more than this would be positive. Similarly, for another kit, it was a different algorithm. So that number has got nothing to do. It's not a thumb rule that, it has to be 42 across all the kits. No, every kit, it's like just like how we have those cutoff values which vary from kit to kit or lab to lab. So the same thing. It's just that Myriad was the first one to introduce the test, and they came up with this score. So it's not that every kit has to have that score only. So that score can vary. So as long as the kit has been validated and they have given a specified score in their report, you can go by that score. Next slide, please. So with that, I think we have understood pretty much in detail about the GI test, GI scoring and the BRCA mutations. So how are we doing in TMH? So we get FFPE tissues of histopathologically confirmed cases of high-grade serous ovarian cancer, breast cancer, prostate cancer, and the kit used is Sophia HRD1. Our platform is Illumina NextSeq 2000. Next slide, please. Yeah, so the kit details is that we have this large panel of close to 28 genes, and we are doing the low pass whole genome sequencing. So there is a deep learning or the machine learning for the pattern which would derive the genomic instability index, or the GII. They don't call it as GIS, and the threshold is 0. And then it takes into comparison the mutation and the genomic integrity index, and with that the score comes. And the library preparations for 28 genes is a different one, and the library preparation for the low pass whole genome sequencing is different. Later on, you can pool and run both the things collectively, and then you would get a detailed report once the assay is done. Next slide, please. So the total cases performed till, I think this data was captured, was till June of this year. And refunded, we refunded close to 19 cases because of suboptimal DNA quality or inadequate tumor content. We successfully performed close to 93. So roughly, I think 10% is what the rejection rate. Next, please. So this is basically the sample report. So here what we are doing is, in the report, whenever you're seeing, we get so many different types of reports. So it's always important whenever you're looking at a report, what methodology is being performed, what exactly, which kit is being used, and what is it detecting, and what software is being used, and what platform has been used, and what all that kit is able to, the report is able to tell you. Next, please. So then the HRD status, like we have given for this specific case, is negative. Why? BRCA status is negative, the genomic integrity status is negative, and HRR status is positive, which means one of the HRR pathway gene is positive, but still this test would be HRD negative. Next, please. So this talks about one gene, which is P10. That is a variant of unknown significance, and it is a tier 3 variant. Just to show you how the alterations need to be written in a molecular report. And then also there are other alterations, so this particular specific gene is in the HRR pathway, the P10. The next one is TP53, which is also a tier 2 variant. And then we have written that CNV is not detected, and there are comments. Next, please. This is the technical information which one need to include in the report, which talks about the what is the HRD status, what exactly does it mean. When you're saying BRCA status, again, BRCA status derived by this specific, it is different. So there is positive, there is predictive positive, there is a complex case, there is predictive negative, or there is negative and undetermined. And also, again, when it comes to genomic integrity score, the QA status talks about what was the quality of the DNA in your sample, and then the GI index status and the score. So all this information is important to include in the report. Next, please. And this is the total gene panel, and then you also write about the disclaimer about the test, like what all it can detect and what all it cannot detect, what are the limitations of the assay, what are the annotations for databases, what you're looking for confirming the alterations. Next slide. So this is across the cohort, the distribution, what we are seeing, HRD positive cases have been positive, negative, and undetermined cases. Similarly, cases which are positive for GI, genomic index score, and cases which are positive for BRCA only, and rest of the cases are negative for BRCA, and HRR genes positive and negative. Next, please. This is the total distribution of the cases. So nearly 40% of the cases are HRR negative, and 39% are GI positive, and there is 11% are GI and BRCA positive, and only 10% are BRCA positive. So if you can see, among the 38 cases, there are 7 cases with BRCA positive, and they are GI positive. And only BRCA positive, if you can see the distribution, these are those 7 cases which are GI positive. But and then HRR positive is 27 cases and TP53. Next, please. HRD status observed across like different entities, different disease that we have got. Most of the cases, what we are getting is the high-grade serous ovarian carcinomas, and then we also get pancreatic adenocarcinomas from breast and prostatic adenocarcinomas. Next, please. And this is the GIS status and BRCA status that we observed across these cancers that we have seen. And if you can see BRCA, we have kind of distributed into BRCA2 and TP53 mutation positive, and then how many were inconclusive. Next slide, please. Just click once. Yes. So here I had talked about BRCA status as positive, predicted positive, complex cases. When you have a complex, it's like variant of unknown significance with coding consequences requiring further inspection. So you would be cautious to call. You will not call that as positive. So that is, of course, you have BRCA positive, but that BRCA is not positive enough to be like, it is not a pathogenic alteration. So that probably you further need in silico analysis, or you need further computational inspection of those. And there could be predictive negative, like variant with coding consequences, predictive of no functional alterations. And then there is frank negative, and there is also undetermined. So based on that, these have been distributed. So we have this BRCA positive, and then there is predictive positive, there is complex case, BRCA negative, undetermined, BRCA1 positive, BRCA2 positive, BRCA1 TP53, and so on. So that's how it has been distributed. But you can see that there is a mixed bag, and still the numbers are still lower. The more number of cases we would do, we'll be able to triage it even better. Next, please. So what are the factors which contribute to this uninterpretable or undetermined status? As I already mentioned, it is a tumor content. It's a DNA input. Sometimes, we really don't want to let go of that case. We feel, okay, the patient has only this limited blocks, and let's try even if the DNA is low. But actually, after seeing this entire batch of these assays, we realize that if the DNA input is low, you should just not touch it. I mean, it's better you have adequate amount of DNA. Otherwise, you would end up wasting all your efforts and getting with a very noisy data or an uninterpretable report. And even tumor content is extremely important. And also, once you might have enough adequate tumor, you will have a better DNA. But DNA library quality, if it is suboptimal, you will not be able to figure out. And functional DNA qPCR, we do not do it, but some of the laboratories do it as a measure of checking the purity of it. So even that would matter. Next, please. So what are the limitations? As I already mentioned, the kind of FFPE tissue which has been used for fixing it, and the tumor area selection. This is extremely crucial. You need a trained pathologist or morphologist rather to tell you like which area to take it, so that you get the adequate tumor content, a good tumor area, and then you can chalk out that and do a macro dissection and take it, rather than just taking the whole of the tissue just like that. And also another issues are these alterations of uncertain significance. These are something which need to be weighed with lots of patience, and we need to really look into the literature. And again, you need to go back every 6 months to just check whether that viewer has moved further, either into a pathogenic, likely pathogenic, or it has gone beyond into being a benign. So we really do not know what to do with that. Even when you have an information for a BRCA1, if it is a variant of unknown significance, you still cannot classify that as HRD positive BRCA. It would be still a complex case, or it could be a predictive positive. And then it's the intra-tumor heterogeneity. So like when it's an intermixed population, it's extremely crucial to pick up and be aware that, what is the adequate tumor representation in that area. And tumor evolution events also, like when the sample was taken, whether it was at the baseline or whether it was taken at the metastatic stage, because these clones tend to evolve. Next, please. So with all that, this is what we have looked into literature, and we are talking about our own experience. So what does the guidelines has to say? So as per European expert consensus, there is not sufficient evidence to recommend tumor testing for other HRR mutations, like for predicting sensitivity to PARP inhibitors. So just because those genes are positive, you cannot say that they can be given PARP inhibitor. And if non-BRCA HRR tumor mutation status is examined, the following genes could be considered, like RAD51CD, BRIP1, PALB2, BARD1. And non-BRCA HRR mutation tumor testing could be beneficial for clinical research. And if germline non-BRCA HRR gene mutations are identified, relatives should be notified by the ovarian cancer patient and advised that they may be referred for a genetic counseling, and this is the strong recommendation. So with that, I would like to say thank you. Next slide, please. So this is the impressive molecular pathology team. So I'm really proud to be a part of it. My sincere thanks to our head, Dr. Sangeeta Desai, under whose guidance we've been doing this commendable work. And definitely, it's not me. I'm just the face of the lab. It's all these people who are in this picture. My colleagues, Dr. Tripti, Dr. Gauri, Dr. Prarthana. So they all have been there with me together in this journey, and with this we are able to contribute to the way we are doing it right now. And thank you so much for patient hearing. I'm open for any questions.
Thank you, Dr. Omshree, for the insightful presentation. There is an announcement. The questions and answer Q&A session will be taken up at the end as a part of panel discussion. And after the panel discussion, there is going to be a short announcement, so stay tuned for that. Now, in continuation, Dr. Sridhar, can you please take down the slides? And now, in continuation to the ongoing HRD discussion, I would like to take this opportunity to introduce new panels added in the diagnostic menu of Karkinos Healthcare. Yeah, so in continuation to the ongoing HRD discussion, we would like to take this opportunity to talk about the newly added panels in the diagnostic menu of Karkinos Healthcare. The first one is the KSG Absolute Homologous Recombination Deficiency Panel in partnership with Sophia Genetics. As already mentioned by Dr. Omshree, the cause and the effect of HRD. In this test, we grab the information from the germline and somatic mutations in HRR genes, and along with check the consequence of HRD by calculating the genomic instability score. Now, this test is a single assay that would include both the assessment of cause as well as the effect. This is an end-to-end application, meaning it will take up this right. It will start from the sample analysis and will end at the report generation with a turnaround time of around 20 minutes. This panel is based on the technology where the target capture technology is used to assess the pathogenic variants in 28 HRR genes. And to calculate the genomic instability score, low-pass whole genome sequencing data is leveraged, on which a neural-based network deep learning algorithm is used to calculate the genomic instability score. Along with this panel, we also have another panel which has been added, which is KSG Absolute Solid Tumor Plus. This panel is an expert design panel to assess the mutations in solid tumors. It spans 42 genes and has a size of around 97 kb. It covers different variant types, not just SNVs, indels, and CNVs, but also 136 gene fusions and as well as loci for 6 microsatellites loci. The genes that included are in this panel are involved in solid tumors that includes brain cancer, skin cancer, lung cancer, and colorectal cancer. So for these newly added panels, if you have any queries, please write us to at lab@karkinos.in. And now, I would also like to point out that to generate the data, we use Novasec X Plus deep sequencing systems that provides higher throughput and accuracy when it comes to applying data service applications at scale. So now we will be having a panel discussion on HRD testing. We have two panelists, Dr. Omshree and Dr. Prashant Kumar. I'll take a moment to introduce Dr. Prashant Kumar, and this panel will be moderated by Dr. Vinod Skaria. Dr. Prashant Kumar is a Chief Scientific Officer at Karkinos Healthcare. He has vast expertise and accomplishments in the field of cancer biology and has done extensive research and is also an adjunct professor at IIT Kanpur. Dr. Vinod Skaria, who will be moderating this panel discussion, is a renowned Indian biologist who needs no introduction. He's a clinician turned computational biologist. His research spans the application of genomics and informatics in clinical and biomedical settings. I welcome all, and let's start with the panel discussion.
Thank you very much, Dr. Aarti, for the introduction. And it's a pleasure to share this panel and moderate this panel with my colleague, Dr. Prashant, and the speaker for the day, Dr. Omshree Shetty. I think I have a very few questions to ask, but you've given a very good overview of what HRD is and what are the clinical utility of it, how is it really performed. But coming back to the clinical scenario, a lot of clinicians still think that they need to first do a BRCA1, BRCA2 testing, and only if it is negative, they should go back to do an HRD. What is your views on this? I think you mentioned that in the last part of the slides, but since there are a lot of clinicians in here, I think it would be very worthwhile that if you re-emphasize that point.
Sorry, I just missed the question. Can you just come again?
Oh, okay. A lot of clinicians actually think that they need to do first a BRCA1, BRCA2 testing, and if the testing is negative, is then we should do a HRD testing.
No,
So what is your...
I don't agree with that, because you would end up, number one, depleting the tissue, subjecting it to again and again. Depends if it is the institution-based lab, at least you will have get back to DNA again. But once you do, you don't get information. Then again, so even the turnaround time to get that report, and then again you go back and do HRD. No, instead, might as well do HRD, and you would get the answer in one go. So I would strongly recommend HRD testing.
Thank you very much. I think you re-emphasize that point very much, and I think all clinicians in here would hear that and take that home. My next question is to my colleague Dr. Prashant Kumar.
So Vinod, can I, Dr. Vinod, can I just add to this?
Yeah, sure, please.
First of all, Dr. Omshree, she always speaks very eloquently, and I think many of us learned today what she has explained from beginning. So thank you so much for participating in this event. Really appreciate. The first question what you raised, what I understand that approx 20% of the patient without a BRCA1 mutation, they harbor HRD deficiency. So it's a good number. So not necessarily that the BRCA1 mutation only, the patient present with the BRCA1 mutation could be considered for the HRD testing, because you will miss out many of those where you would still identify the HRD deficiency. Yeah, Vinod.
Yeah, correct. Absolutely right. And my question is to you, in terms of NGS testing, HRD is another test and the recent test that has come into the menu or the armamentarium for target therapies. What do you think is the real challenges in implementing NGS on a wider scale in clinical settings?
I think this is a very interesting question. This is really interesting question. See, what I actually wanted to ask Dr. Omshree, what you are asking me this question, but many of the listeners will understand that HRD resulting from the epigenetic changes, and especially the promoter mutation in BRCA1, you will miss out doing the NGS. So this is something which is very interesting. So not necessarily that everything you will identify during the NGS. And another point I would like to pitch that, however, it is amazing. You can tailor the treatment, especially for ovarian cancer. Almost 48% of the ovarian cancer because of this HRD. Prostate, there are 2 FDA-approved drugs recently approved for the prostate also. So this has done remarkably good, especially for tailoring the treatment. However, the bigger challenge would be that if the patient can afford the treatment of the PARP, and if I, being a clinician, recommend that every patient coming with ovarian cancer and do the testing, would you provide, and it would be suffice to say that the patient can afford? So for me, it is always a big dilemma that if I would say you to go for the testing, but then what would be the next strategy? And I'll be very happy to listen the same comments from Dr. Omshree also. Thank you.
Dr. Prashant, you nailed it. I mean, it's always pleasure to discuss, I think. I mean, it's a very pertinent point that you pinned out. And also, our dilemma in the hospital is initially when this test wasn't there, the clinicians are like, please bring in the test. Like, let's see, like by the cost of one dose of olaparib, patient can do this test. We said, okay, we brought the test in, and then the test started becoming useful. And now the clinicians are requesting, can you please reduce the price of the test? Because, now the drug cost has reduced. Now it is at almost half the price of the test. Earlier, we used to tell the patients, okay, at one dose of your drug, you can do this test and then you can be taking the medicine. But now the drug is even half the price than what the test price is. So I really don't know what to do. So I'm like, no, it's a big challenge for a laboratory because these reagents, I mean, I guess Sophia people are on board. Please listen to it. Bring down the price. It's always, I keep trying, to Illumina, to everyone, bring down the price because a country like India, we need to be more economical. I mean, because patient is paying from his pocket. And the affordability is one big challenge. So like clinicians might require, there is an FDA approval, but affordability. Very rightly pointed.
Right. Thank you very much. And I think that's a very, very right point that you sort of put across. Now, with generic versions of olaparib coming into the market, the prices are reducing. And when the prices of the drug reduces, it's just natural that people think that the price of the test should also reduce in a proportionate way. And the second question is, HRD testing is also one example where it started with one cancer, like many other tumors and many other targeted therapies available. They started with one cancer type, ovarian cancer, and increasingly there are clinical studies for a variety of newer cancers for which HRD is applicable or is being tested whether it is applicable. And with PARP inhibitors prices coming down, do you think, or what do you think is the trajectory of HRD testing? Is it going to be a pan-cancer indication, like, for example, immunotherapy? Or is it going to be very few cancers that it is going to be actively used for?
Currently, if we go by the guidelines, there are no indications as such. So we would still like to stick to that. I mean, of course, in prostate cancer, it is coming, in breast, it is coming, and the prices of the drug, as you rightly mentioned, has gone down. But the testing cost, I think maybe with the more advanced sequencing technology, we should be able to bring it down over the period of time. But that's like a due course of time, and there's a journey, and there are still many unanswered pockets. I mean, we just cannot say, yes, this is the one-point solution and this is it. Like Dr. Prashant rightly mentioned, there are those epigenetic changes, there are those methylation markers. So like, it's like, we are blindfolded and we are trying to gauge the elephant. You might say, okay, this is something, then something else would come up. But however, having saying that, with the framework of information and knowledge what we are having with the guidelines, I would rather say at least breast, pancreatic adenocarcinomas and prostate are definitely on the way.
Thank you very much. And I think since we are about to close the session, we would open it up to some of our attendees to ask questions. If you have a pertinent question, you could put your hand up and the team will enable you to ask the question. I think there's a question from Dr. Jyothishankar Roy Chaudhary. If you could go ahead with your question. Dr. Jyothishankar, you could unmute yourself and ask the question. I think we lost him. I think we have a question from Ashish. You could unmute yourself and ask the question.
Great talk, Dr. Omshree. I had two quick questions. One was for HRD positive patients, a lot of them get PARP inhibitors. For HRD negative, is there a class of agents or therapies that are kind of indicated? And the other question was the distribution of HRD positive and negative that you showed in the TMH cohort. Is that so? That's very much a function of the genetic makeup of the cohort, right? So it would look very different if the cohort was in the US or Europe or even within India. I'm just curious. Is that cohort, like, does that cohort come from Maharashtra or a certain geographic or ethnic and hence distinct genetic makeup?
No, so this is not a study base per se. So these are the cases which were sent to the laboratory for routine testing. So TMH being a tertiary cancer center, so we get patients all over the country. Having said that, we can say that this could be a pan-Indian distribution, but still this number is relatively small. So these are like patients in the advanced stages, like in different stages. So we really do not know. And then 90 is still a very small number again in that bifurcation. So probably the data would evolve, and then whatever would look here might be different, like in a specific geographic region or ethnicity. So I mean, currently I cannot say that it is not a specifically picked up cohort. It's like a sequential patients who have come for testing, and we have just shown that distribution. Coming to your first question, very valid question about HRD positive. Yes, we do have therapy, but for HRD negative, I think it's only platinum-based chemotherapy is what they're offering, and rest I think the oncologists or the clinicians are the best judges to decide on that. I can only say that yes, this is positive or this is negative, and then that is up to them.
And a quick rejoinder on the drawbacks of the assay. You mentioned that it is not very clear, like you could get very different results on the timeline of the test, right? So when the patient presents to a medical oncologist or a surgical oncologist, do you right away recommend HRD biomarker test, or like what is typically the time instant when you do the test for this class of patients?
Thank you for that question again. So very valid point, so which means you heard the talk very carefully. So this means, the clone evolves. I mean, like when you're taking the baseline biopsy, so I mean, that's what we even see in lung cancer. I think Dr. Prashant would agree, like in the mutation profile, what we are seeing. So the baseline would have a certain set of mutations, whereas then the patient is subjected to routine, chemotherapy or a normal regimen. And then when the patient is in an advanced stage, so the clone, what you must have seen at the baseline, would have modified. I mean, that would have evolved, or it would have either damaged, or any new clone of the tumor cell would have emerged, and they would have a different genetic makeup, or maybe the damages must have accumulated and they can create some other alteration altogether. You will even have many of the resistant mutations. So that way it is varying, and the timeline then definitely.
Thank you.
Yeah, thank you very much. I think there's a question from Dr. Jyoti Shankar Roy Chaudhary. Could you please unmute yourself and ask the question, please?
Hello. Yes. A lot of the data is from solid cell tumors. What about the data for HRD testing in hematological cancers, myeloma, and we know there's a lot of chromothripsis, etc., and evolution of the tumor. So, do you have any HRD testing in liquid tumors?
No, sir. So again, a very valid question, sir. But ours is a solid tumor molecular diagnostics in TMH, and we are only doing the solid tumor testing. Predominantly, the cases what we are getting are from the high-grade serous ovarian carcinomas, and very few breast cancer cases we are getting. So I have no experience in liquid tumors. We have not looked into it.
Okay, thanks.
You're mute, Dr. Vinod.
That's okay.
Sorry.
I mean, I had some data. I worked on multiple myeloma, and since we did find, and Vinod knows about it, I've discussed it with him also, the evolution of the tumor. And HRD, what I did find that there's so many of the pathways that are altered in myeloma and also in leukemia. So the data regarding that and usage of the PARP inhibitors in hematologic cancers, the resistant hematologic cancers which are resistant to even checkpoint inhibitors, would be very important. And we could have, if we had some local data from TMH, that would be interesting. That's okay.
And look into,
yeah.
There is a molecular hemat lab, so.
Yeah.
Thank you. Thank you very much.
Thank you.
I think there's a question from Dr. Jyoti Bajpai. There's a last question. Dr. Jyoti, you could unmute yourself and ask the question.
Sure, sir. Thank you, Dr. Vinod. And good evening, Dr. Prashant, Dr. Omshree. Dr. Omshree and Dr. Prashant, I have one question for both of you about the genetic counseling part. How can genetic counselors play a role in making HRD available for patients? Whether it should be done, counseling should be done after the HRD test has been done or before that? Because I understand that if HRD, if we get some germline mutations, certainly we would like to do genetic counseling after the test is done. Do you think that before HRD, genetic counseling can play a role for HRD or not? Just want to understand that.
Dr. Prashant, would you like to take this? I'll answer it.
Yeah, so for me, it is straightforward. If it is coming for ovarian cancer, I would rather go before, because I understand almost 48% HRD is present in ovarian cancer.
Okay.
So depending on the cancer type and what Dr. Omshree in the beginning, she mentioned one of the slide that 4 prominently cancer where we use, starting from ovarian, breast, endometrial, and prostate and pancreatic, 5.
Yes.
But it all depending on which cancer type you are dealing. But for me, ovarian cancer is very clear. You should do it before. Yes, Dr. Omshree, please.
Yeah, I think that's right. We would prefer that, but the real life scenario, in TMH, what's happening is that patients are coming up front and then we are getting them tested. And in case if there is an indication for germline, then we are referring them to a genetic counseling clinic. So technically it should be the other way around, but because of the load and constraints, they have been referred to only if there is any germline mutations detected.
So basically, what I understand, if it is possible to do, it is better to do before HRD testing. I think one more reason is there that we can talk about science, we can talk about knowledge, everything, but to explain it to the patient and how it is going to help them, it is very important. Yeah.
Absolutely.
Thank you, Dr. Prashant. Thank you, Dr. Omshree. Thank you, Dr. Vinod. Thank you.
Thank you.
Thank you very much, Dr. Jyoti. And I think we are about time to close the session. Thank you very much for my panelists, Dr. Omshree Shetty and Dr. Prashant Kumar, for the very insightful session, and also taking questions from the viewers. I hand it back to Dr. Aarti.
Thank you, sir. So before we wrap up today's session, that was very insightful and hope everyone enjoyed it. We have a course coming up on this Saturday on 14th of September, which will talk about the interpreting the genetic reports and would cover the key topics from fundamentals, germline and somatic testing, variant interpretation guidelines, analysis. Those who are interested have a chance to scan this QR code and can register for the same. I'll be holding up this slide for a moment. This will also be shared on the LinkedIn page of Karkinos Healthcare. So thank you all. Thank you, Dr. Prashant Kumar. Thank you, Dr. Omshree Shetty, and thank you, Dr. Vinod Staria, for holding up this session on HRD testing, which was a very relevant one. And thank you to all the attendees for the questions. See you soon on this Saturday with a course on interpreting genetic reports. Till then, take care.
Thank you, Dr. Aarti.
And it's always pleasure to share the screen with Dr. Prashant. He's really a friend, and we like to discuss these things, and it's really an immense pleasure to be with you here today. Thank you. Thank you so much, Dr. Vinod, and thank you, Dr. Sridhar. Thank you, Aarti.
Thank you very much.
Thank you, everyone.